There. Okay. You can just see the like title slide, right?
Yep.
Okay, cool. So I can't see the chat or anything else like that when I'm sharing like this. So if someone wants to just shout out if there's anything that I should discuss. Otherwise, we will get started. So thanks for coming to our roundtable. We're going to do a number of topics today, our normal COVID epi and updates, measles, just because that's been in the news. We've gotten a number of emails from you guys asking for TB rates for your annual risk assessment. So I'll show that slide. A little bit about some new hand hygiene resources. There are some updates to the IDPH reportable disease list that Kelly will talk about, and then we will do a winter storm emergency preparedness scenario and questions and answers. And as always, just ask away during the presentation. So I'll do this part fast. COVID's in a good spot right now, nothing crazy. And outbreaks are actually in a good spot too. Only 8 of you have had COVID cases within the last 14 days, which is great. Variant, it's still all Omicron all the time. And then, as you can see in the country, everyone's doing pretty well too, except for 2 counties. But Cook County is currently low hospital admission rates. And in terms of other respiratory diseases, there is still a fair bit of flu going around. So usually the season's like over or winding down at this point, but it's still happening a little bit. And you can see that in the top left graph. How usually it'll peak, go down, and then might peak again with a B wave, and it's just kind of lingering there. So please keep flu in the differential diagnosis when you're doing COVID tests if they're, especially if they're negative, consider doing a rapid flu test or a respiratory virus panel. These are no changes, so no routine staffing requirements, no routine residence testing requirements. Just again, always test people if they're symptomatic, if they've had a high risk exposure, or if you're an outbreak and they're indicated for testing. So one exciting thing that we've mentioned in the past, but is finally happening, is our CNA focus group. So as you might know, we got some money from CDC to do focus groups with SNF CNAs in Chicago. And the topics are staff retention and then infection control. And obviously, we expect to hear that money would help with retention, but we're hoping to get a lot of other answers that would be also less expensive. And then we can share that back with you so that hopefully you can use that to help retain your staff, which will save you in time and money and improve job satisfaction. So again, the only people who are eligible are CNAs working at Chicago-based SNFs, but they can be facility or agency. There's a $75 incentive for participation. It's an online, like basically they can do it from their phone or their computer. It's 1 hour, so 75 bucks for an hour. And then, like I said, we'll report results back to you at a future roundtable. So we can see, and I'll show you in the next slide, the facilities that are represented by people who signed up, but we will never be able to link. If someone's like, oh, this is making me unhappy at my job, we're not going to be like, oh, that is from facility X. That's not how the results come to us. So we will not be able to, like, you can't be like, oh, can you tell me what they're saying about Admiral if you're Admiral? And then we can't tell you that because we won't know, but we'll send a report in aggregate. So we've been hitting the streets, dropping off these flyers. Thank you for those who are letting us post at your time clock. And I just wanted to say that these are the facilities so far that have had at least one CNA sign up. We're very grateful for those of you who have been around for a while. You might know we had focus groups on vaccinations maybe 2 years ago, and recruiting was very hard. So we're very happy about this, to have this many facilities represented. For those who did not see their name on this list, a lot of you, we've already gone out and dropped the flyers and posted them at your time clocks. But what we could really use help with is, so we have 28 registrants so far, and we have room for up to 60. So definitely still have additional slots. For those of you who are on the meeting and represent a specific facility, if your facility's name is not on that list, we'd really appreciate it either allowing us to come out and post a recruitment flyer at your time clock. We can come out, come in, tell the receptionist we're there, go ask where the time clock is, tape it up and leave. You won't even know we're there unless you want to meet us. Or we can email and share, and then you can share the flyer with your CNAs. And then for those corporate reps that are on the call, we'd love it if we could email you the flyer and you share with leadership. We still have some larger networks like the Aldens where we don't have any representation, and we'd really like to have some from those facilities. And then shifting gears completely, here is the Illinois TB case rate from 2023. So that's the last data that's available. So for those of you who need to do TB risk assessments, you can use this data. So for Chicago, it's 5.62 cases of active TB per 100,000 people. And then Cook County is lower, 2.97. Illinois is lower than that, 2.75. And then the rate for the country as a whole is 2.9. So now we'll talk about measles. I think most of you know that there's been an outbreak occurring in Chicago and some of the surrounding counties. Most of the cases have been associated with new arrivals in a particular shelter, but it's slowing down considerably, and you'll see in the epi curve I'll show you in a little bit, but we are seeing some community cases now that don't have any ties to the new arrival shelter. Although to date, to my knowledge, we have not seen a single case that has any affiliation with a SNF, no staff, no visitor, no resident. We do ask very detailed questions about where they were in their incubation period, or like where they could have gotten it from and where they were when they were infectious, and nobody has mentioned a SNF or other senior care facility to my knowledge. So just general information on measles. So measles, also sometimes known as rubeola. So I'll talk about titers in a little bit, but for my titers, like for example, it says rubeola IgG. So they're the same thing, but it is not the same as rubella. It's an acute viral illness. It's spread via large respiratory droplets and airborne transmission. So those really small particles can remain airborne for up to 2 hours after someone with measles leaves an area. So for example, if you have someone with measles in an ER waiting room and they don't put the appropriate precautions in place because maybe they don't know that they had measles, they will look at the list of patients in that ER from when the person got there until 2 hours after they left. And any of those people could potentially get measles if they're exposed. So it's very highly contagious, one of the most contagious diseases in the world. A person with measles is contagious from 4 days before their rash onset until 4 days after their rash onset. So it's not the entire, if they have the rash for longer than that, they're only really contagious until 4 days after. But 4 days before, all they might have is, some like general flu-like symptoms, maybe a runny nose. So it's really hard to tell if someone's going to develop that rash. And then luckily, we're a pretty heavily vaccinated population, but in general, what studies have found is 90% of people who are susceptible, so meaning they're unvaccinated, they've never had measles before, they will get measles if exposed. So using that ER analogy, let's say the ER was full of unvaccinated people, 90% of them on average would get measles for that one person being in the same airspace as them. It's a pretty long incubation period, which also makes it difficult. It's not like some diseases where, norovirus, where it's like a couple days, if that. It's an average of 11 to 12 days from when they're exposed to that prodrome. So again, that's like the runny nose and fever and things like that. And then an average of 14 days from exposure until that rash onset. I can't see if there's questions, like I said. So if someone on my team just wants to interrupt me, then let me know. So in terms of symptoms, so like I said, prodrome, so this is before the rash. It's a fever, just generally feeling unwell, and then a cough, coryza, which is a runny nose, and conjunctivitis, so like red, watery eyes. That's usually how it starts. And then the rash will start, the fever will still be present when the rash is there. That's important to note. It's not like the fever goes away and then the rash starts. And generally speaking, it'll start on the face and go downward. There have been a couple cases, especially ones that were already partially vaccinated, where it's presenting a little bit differently. But generally speaking, again, it starts at the top of your body and goes downward. And then a large proportion of people with measles will have Koplik spots. So that's those little white dots on the bottom right. So they'll have that in their mouth, although I have heard anecdotally that not a lot of people in this outbreak have that. In terms of complications, about 20% of unvaccinated people in the US who get measles are hospitalized. For this outbreak specifically, it's been much higher than that, but most of the reason for that is because since the cases are in a new arrival shelter, which is a congregate setting without like defined walls and things like that, they are keeping them in the hospital a lot of times until they're outside of their infectious period, because if they put them back in the new arrival shelter, that would prolong the outbreak. So there can be complications for children, for example, ear infections, pneumonia, about 1 to 3 per thousand will die, and then some others will get some pretty severe encephalitis. And then pregnant women who get infected with measles can have some severe outcomes, premature stillborn and or low birth weight babies. So the vaccine, it's a live attenuated vaccine. In the US, we don't really have a single measles vaccine. They have that in some other countries. So the measles vaccine is usually combined as an MMR. So measles, mumps, and rubella. And again, rubella is different than rubeola, or more recently, measles, mumps, rubella, and varicella. So hopefully all of you have that and your kids have that. But those are what the shots names are, MMR or MMRV. It's part of routine childhood vaccination series. I'm pretty sure it's required at CPS unless there's an exemption. The first dose you get between 12 to 15 months of age, although if there is a child who is traveling internationally to a place that has measles, or someone who is exposed to someone with measles, they can give that dose as young as 6 months, but then they have to repeat it when they're of age. And then the second dose is between 4 to 6 years of age. So one of the things we've been a little concerned about, but it hasn't happened too much, at least in the general community, it has happened in the new arrival shelter, is kids under 4 would not have the full protection with the 2 doses. The good thing is it's an incredibly effective vaccine. So 1 dose is 93% effective at preventing measles, and 2 doses is 97% effective. So that's really good. It's pretty high efficacy. And then one thing to note, and this has happened once or twice, I think, with this current outbreak, is some people who get the vaccine will get a rash after that vaccine, but it's not contagious at all. It's short term and they might get that fever as well. They do have tests to determine whether that would be what they call MIVA, so like vaccine associated rash versus actual measles. And again, if they get that vaccine associated rash, that is not contagious to other people. So in terms of this outbreak, this is measles cases in Illinois. So as you can see, there's been a little, some spikes, but most of them are international travelers who are coming back. But then this year it's 66 cases, which is a lot, and we're only in April. The good news is it's slowing down a lot. So as you can see by this epi curve, we started seeing cases at the beginning of March. There was a big oh my God, I can't think of the word, peak in end of March. And again, that was almost exclusively people at this new arrival shelter, one specific new arrival shelter. And then it came back down, which is great. We've spent a ton of efforts vaccinating people at that shelter, isolating people who had measles or who were susceptible to measles. So we've done a really good job of pretty much containing it to that one shelter. I think there might have been 1 or 2 at other shelters, but it's really stayed within that space, which is unfortunate, obviously, for the people who got measles, but a public health success that it was kind of contained. There have been, though, as you can see, kind of in the April region, one-off cases that are in the community that have no affiliation with the shelter and also usually no affiliation with each other. So it's kind of unclear where they're getting it from. But on this dashboard, again, I have the link on the bottom of the slide, same link for this one. They do keep really good track. Like what I said, we do very thorough interviews with these people who have measles about where they were before they got sick and where they were when they were potentially infectious. And any of the community locations are posted, like shopping centers, restaurants, healthcare clinics are posted on the same website. The link is at the bottom, the date, and then the time range. And they've been able to do some pretty cool stuff with this. So they can get lists of names, for example, from Venture cards that are tapped on buses and things like that. So that's cool. And then they can alert them that way. They can, they've been contacting Uber when there's Uber drivers implicated. Like it's pretty cool. Or like who might have been exposed that they can talk to. So lots of cool stuff with technology lately. But so these are the lists of of public locations, and they update this regularly every time there's a new case. And as you can see, there hasn't been a new case, I think in the last week. So that's good. So it's definitely slowing down. So that is that. And then, as you know, and we talked about last time, IDPH did release a siren with information for long-term care facilities about measles. Again, we have not seen any measles at least in Chicago, and I don't think in the other counties affiliated with any kind of long-term care facility, which is great. And the other good thing is that most of your resident population is old enough that they are considered immune. So the siren alert, and we've been sending that out in our follow-up emails. It has a lot of different topics, so I just have the list there. But the things that are probably most relevant to you is you really should assess residents and staff for their immunity. So immunity would be indicated by them having 2 doses of that measles vaccine at least 28 days apart. So it could be MMR or MMRV, or if they lived in a different country, just the measles one. But they do need to have a documentation. You shouldn't really go by them verbally self-reporting. They could have laboratory evidence of immunity. So I don't know all the ins and outs of Medicare and reimbursement, but in theory, if you have a resident who was born after 1957 and who also doesn't have any shot records, billing permitting, again, I don't know all the ins and outs, you could have a titer draw. So it's just like taking blood, and then they'll look for IgG, which is indicative of previous disease or vaccination, and that would be sufficient. And then laboratory confirmation of previous measles disease, which I doubt any of your staff or residents will have, or birth before 1957. So as long as they meet one of those criteria, you can consider them immune. I know we've been getting a lot of messages about vaccination records and people having trouble finding those. So for residents born after 1957, and those of you who do have eye care, which I realize not a lot of you do, and even if you've been trying, it's hard to get, you can search the registry for residents to see if they have any documented vaccinations for MMR. And the registry is great for people who are vaccinated in Illinois, but isn't always great about outside of Illinois. But if they're in there and they have 2 doses, then they're considered immune. I've said this before, I will say it again, you are not allowed to use eye care to look up staff vaccination records. That would be a HIPAA violation. So please don't do that. And we talked about this last time too, but under the section of the administrative code that applies to skilled nursing facilities, you are supposed to or required to have a medical file for each of your employees, and that would include the employee's vaccination records. So you do have the authority to request that your employees provide you vaccination records. And then staff can request their own vaccination records using Vax Verify. There's a link on there. If it doesn't have their records, they could check with their doctor's office or parents, and I forgot to put on here, or school, to see if they have records. So they could call, if they went to CPS, for example, they could try to get a hold of them and see if they have the records for them, especially if they went relatively recently. A question we got a lot is it mandatory that staff get the MMR vaccine? No, there's no current regulation requiring that nursing home staff be vaccinated against measles. But like I said before, you are kind of required to ask them for their vaccination records. We do support staff and support and encourage facilities to offer that vaccine to interested and eligible staff. Again, it's not required that they get it, but it would be nice of you if you have the funds and the ability to offer that to staff to help increase that protection at your facility. And then work exclusion, again, this has not come into play yet, but in theory, there could be someone in the community and then the staff member could be living with them or exposed to them. And if they're unvaccinated, they must be excluded from day 5 following the first day of that exposure to the case through day 21 following the last exposure to the case. So many days of not being at work. And that might be something to motivate staff to get vaccinated as well. And I think I had this in the last presentation as well, but just in general, make a plan for what you'll do if a staff member, a resident, or a visitor tests positive for measles, if a staff member can't find their vaccination records, or if a staff member without immunity is exposed to a case. So again, like a household member who has measles. And now I'm going to pass it over to Kelly, our epidemiologist. Hopefully she's
Hi,
on.
hi, everybody. My name is Kelly Wobley. I'm the senior epidemiologist of the HAIR program at Chicago. I just wanted to touch base on something that you guys should all be aware of. So recently updated was the Illinois Administrative Code. And this went into effect on, I believe it's actually 2/27. I have the date wrong there, but regardless, end of February. And if you aren't familiar with this, it's like the public health code by Illinois that talks about what is notifiable in our state and how to control um, the spread of these notifiable diseases. So next slide, please. So there are updates to the entire code, but today I'm just going to focus on what this means for you specifically for the XDROs, since that's kind of what we tackle here. Next slide. So I've highlighted here, but XDROs, and this would be your CRE and your Seek Canada ORIS, they're now reportable within 3 days. They're considered class 2 organisms, and I've highlighted here where it says that. And what this change was, is it previously was 7 days. So this now means that within 3 days of receipt of a lab result that's positive for CRE or C. auris, you would need to report to XDRO. Next slide. This part of the code just highlights who is required to report to the XDRO registry and who is required to query the XDRO registry. I wanted to highlight here that SNFs fall under the long-term care facilities and who is required to report. And then the query section is new this time around. And so skilled nursing facilities are also required to query the registry upon new admissions to see if they have a history of XDROs. Next slide. And then under the info that's required to be reported, I highlighted here again the 3-day rule part. And then part D is also an important section because you may get requests from us from time to time where we ask you to fill out something called a case report form. This actually falls under this part D where it says upon request from the department for additional information that you guys should, work with us to kind of acquire what we might need. Next slide. And then I just wanted to highlight in here too, there's a section of the code that kind of talks about what we use this data for your own knowledge and like why this is important. So we do use this data for a variety of reasons, and most importantly, assessing the burden of ex-zeros in healthcare facilities in Chicago, and then also to identify clusters and outbreaks in order to implement prompt containment strategies. The code also covers confidentiality for our side and what we are able to release in regards to statistics. So that's also there for your knowledge. Next slide. And then I want to highlight that there is a team member on our team that is awesome and helps us to helps you guys to get XZero registration. Sometimes it is a little bit of a process. So Tassa Proctor will walk you through that, and I have put her email here. If you are one of those people that may not have access to this registry yet, she will be able to help you get that. Next slide. And then I just wanted to also kind of flag here that there is an updated reportable disease list poster. If any of you guys have these hung up about what's reportable, this has been updated and is here. My understanding is I was on the website yesterday and it wasn't updated on the website, but we do have a PDF version that we can send to you or put in the chat if you would like that. But this is updated and effective as of February 27th, 2024. And that's it for me. Thank you.
Thanks, Kelly. I'll pass it over to Stephanie now.
I just want to show you the APIC toolkit for patient hand hygiene. We have shown you resources before for hand hygiene, but this document is great if you're looking for guidance on how to educate residents and visitors. Traditionally, when we see education for hand hygiene, it's geared towards your staff. However, we are starting to see new initiatives that are starting to include patients because patient hand hygiene is just as important as staff hand hygiene. When you're looking through this toolkit, it'll cite different articles. One of the ones I have here is looking specifically at the patient hands. It found that 62% of all patients in a hospital that stayed for more than 7 days had enterococcal hand contamination, compared to 10.7% of non-hospitalized adults. So that's more than half. Another study sampled patient hands and room surfaces, and they were specifically looking for multi-drug resistant organisms. And they found that 10% of patients were already colonized at the baseline. And then when they tested the rooms, 29% of the rooms were contaminated within a 24-hour period of the patient being admitted. So it doesn't take long for these pathogens to spread. So we're seeing a lot more patient-centered hand hygiene, and it's definitely the next step towards infection prevention. Can I get the next slide, please? The toolkit is divided by type of setting. If you're looking for long-term care, I believe it's section 3. One of the ones you'll see right away is they have the 5 moments of hand hygiene, and you've probably seen this before from the CDC. The one from CDC is specific, like for healthcare workers. The toolkit has created 5 moments of hand hygiene, but for residents and visitors. It's very similar to the healthcare one, but the wording has changed a little just to accommodate more of the interactions that residents and visitors will see. Like number 1, just teaching your residents not to touch their wounds, devices, or face, and if they do, clean their hands before and after. Number 2, before eating. 3, after using the restroom. 4, after contact with frequently touched surfaces. And 5, when entering or leaving a room. So very similar, just kind of a few adjustments from the healthcare one. Can I get the next slide? So as far as what you can do is you can definitely print out some of the visuals that are in the toolkit, and you can post them in your high traffic areas like your front desk, living room areas, therapy gyms, and cafeterias. Definitely use them as visual alerts just to remind your residents and your visitors when to perform hand hygiene. If you have any type of welcome packets or like emails that you send out to the visitors, you can definitely include that as an attachment just so they're kind of aware and kind of read through that. And then make sure you look through to see where your dispensers are located. Check your therapy rooms. How many do you have there? How many do you have in your cafeteria? Think about like how far does somebody have to walk from the cafeteria if the only dispenser is like located in the hallway. Things like that, just so that you can see where you need to put more dispensers, and as well as doing audits, if you don't do them already, just to make sure that there is product in the dispensers. That's something like your housekeeping or EVS team can do. You can do it like once a week kind of thing, twice a week. So I have linked the toolkit, and it also includes other documents and like visuals that you can definitely print out. So definitely check it out. The link is on the first slide, and it will be available when we post the slides as well.
Thank you. Okay, and then the last part of our presentation, I'm going to introduce Josh, who's going to go through a winter storm exercise. Let me stop sharing my screen and
Thanks,
make
Liz.
you a presenter. Hold on, let me find you on this list. Where are you on this list?
Oh, hopefully I'm there.
Is it under your?
Should just be under Josh Dice, yeah.
Okay, I have to scroll for a long time. Why is it not? Hold on a second. See more. Oh, there, I got you. Okay.
Excellent.
Make a presenter. Okay, you're good to go.
Excellent, thank you. Okay. So, want to thank you all for allowing me to kind of speak here today. My name is Joshua Dice. I'm with the MIR Consulting Group. We partner and collaborate a lot with the coalition, and one of the taskings this year was to create a off-the-shelf package for long-term care facilities, really focused on winter storms. So it's actually kind of crazy that it's already May, rapidly approaching that. So as we prepare for next winter, which will be here before you know it, we thought it'd be really positive to create a scenario where there was this true catastrophic winter storm and develop the material needed for folks like yourselves on this call and then elsewhere to be able to pick something up and actually have this facilitated conversation on something like this. So that's what we'll be going through today. I'm going to try to fly through these slides, and if you have any questions, I can't see the chat anymore, so please feel free to interrupt me, and we'll go from there. So a general timeline for this effort, we started these conversations in the midst of winter back in January. Again, it's kind of crazy that it's almost May, and you can kind of see what we've done thus far. So we had the initial planning meetings and scenario scoping. That's where we kind of landed on wanting to do a winter storm. We then moved into February, where the MIR team built out the scenario, drafted the objectives, and had those some of those really early preliminary conversations with Mark McCarville, who's our primary contact for this effort with CDPH and the coalition to really get the thumbs up from all those folks involved. So we liked the scenario. It really does kind of push the envelope from what was developed in the past. And that something that we hope to convey through these types of engagements and in the materials is that you're really not supposed to succeed at this. Like in this scenario, it's really going to push the boundaries of your response and preparedness plans and procedures, and that's okay. To be stressed by this and to learn and to use this as a learning opportunity. So I wanted to make sure that was conveyed here, and you kind of see it throughout the documents as well, and you'll see it as we move through these slides. But this is really the project plan. Through March, again, we had some subject matter expert facility rep reviews. So what was missing in the current material? One of the primary things that came out of that was we needed to include food as a more fragile supply chain. So we went back and added that, but that was one of the main outcomes of those facilitated sessions. Now in April and May, we have decided to add on to the existing package and create an outpatient facility version. What's currently available or will be made available in June, as you see here, is the long-term care facility, but we will also be looking to pilot this scenario as well in the next month or so. So if you do have interest in doing that after hearing me chat a little bit about it today and seeing some of the material, please let me know. We'd love to facilitate this conversation with you, and through that, hopefully identify some gaps and areas of opportunity before the materials are actually published in June. So the product itself again, is truly off the shelf, or as off the shelf as it can be. So it will include a situation manual that has your scenario, your objectives, the scenario narrative, questions, the modular breakdown, everything like that, everything you need to actually work through the scenario. Everybody will have access to this, in addition to a facilitator instruction video, presentation slides with and without narration. It is not my voice. It's not Steve's voice anymore. We have a service to help us out with that. So we're really excited to kind of pilot that out. In addition to have an exercise evaluation guide and after action report template to kind of help in those back end components of not only evaluating but drafting those improvement plans and things like that. So this is the package. It's a 5-document package, or 6 when you could count the slides with and without narration. I know I spoke to this a little bit, but again, that's just the purpose and scope. This is off the shelf, or as off the shelf as it can be. There's probably some tweaks at the individual facility level that will be required, but we tried to get it as close as possible to being plug and play. For any non-hospital organization within the coalition, focusing on continuity of healthcare services in response to a severe winter storm. So really diving into those command and control components, communications, medical surge, and continuity of operations. There are 4 objectives for this scenario that we've drafted capability-wise. There's foundations of healthcare and medical services, healthcare and medical response coordination, continuity of healthcare, and continuity of healthcare service delivery. So that first objective being to ensure a common understanding of those plans and policies that may be activated during such an incident. Objective 2, evaluate the ability for non-hospital facilities to establish and maintain communications. We really play with the communication infrastructure in this scenario. I'm taking you guys offline. What does that look like? What will happen if this happens throughout the night, or for multiple days, as kind of illustrated by the scenario? Objective 3, examine key factors of decision making and those contingency care characteristics, and maybe in those crisis standards of care. Procedures that may be needed to be activated at the individual facility level. And then 4th, assess the ability to maintain and perform essential medical services. The exercise itself, when we will pilot this, hopefully with some of you folks online, it's about a 3.5-hour exercise. So that's at least what we anticipate, about an hour for each module, with some time up front and in the back end to both review the exercise overview and actually get it kicked off. And then on the back end of having that hot wash debrief discussion, where we can identify areas of opportunity and strengths just right out of the gate, recognizing that there's a bit more of an analysis component after the fact. Here is the scenario summary. So in conversations with Mr. McCarville and the coalition and several members of the team, the 2011 Snowmageddon really served as the backdrop for this. I spent a lot of time researching it. And I know likely some of the folks on the call today actually lived through this and hopefully can remember some of the things that may have transpired, but that was really the backdrop and the motivation for developing this scenario. So freezing temperatures and wind gusts, emergency authorities suggest power will not be restored for 5 to 6 days. Hospital and non-hospital facilities are required to rely entirely on backup power generation. The on-site facility manager has informed staff that the water main has burst, requiring a temporary shutdown of the heat. Internal facility temperatures can start to drop. Regularly scheduled delivery of critical medical supplies and equipment up to and including food and PPE have been delayed, just given interstate closures and just not being able to pass the roads, and then strong winds and ice accumulation on power lines and cell towers really knocks out the communication and network connectivity. So as I mentioned in a few minutes ago, really trying to stress response plans. This is not a scenario that is you're supposed to succeed at. It's really just supposed to be a facilitated conversation on what can we do better? What do we currently have in place? What do we not have in place? And where can we improve? Just a really quick deep dive into the actual module structure. There's 3 modules, as you saw in the agenda: that incident onset, that warning and recognition component, so that what happens when you have 72-hour notice that something catastrophic is going to happen, what's going to happen with corporate, if that's a factor, or how that's and how's that communicated throughout the organization structure, up to and including patients, family members of patients, family members of staff, and maybe with some distributors. So what does that communication look like early on? Then we move into the actual infrastructure and supply chain disruption. What happens when we literally and figuratively shut the faucet off for some of those key supply chains or utilities? And then module 3 is a little bit more of a deep dive into, okay, now that everything is shut off, now what? Exploring those crisis standards and contingency plans and rationing and things that may be required. Key tasks by module. Again, you see the 3 modules here. Module 1, notification, recognition, and communication. What's the command structure that looks like? What does the command structure look like? How is the event monitored and assessed? Again, at the individual facility level, up through corporate, and maybe even back down to the individual care provider and patients and their family. Infrastructure, supply chain disruption. What is that ongoing response to the intensifying storm? What's the impact to the facility operation? What does the backup power and utility infrastructure look like? How long can you go on a generator? And then, of course, safety and security during those events, kind of diving into, okay, the temperature's dropping. How can we make sure that our patients and those under our care are comfortable and safe and healthy? And then module 3, that continuity of operations, response, again, continued response to the intensifying storm. How are we prioritizing, resource management and conservation? And then again, those continuity of care and essential services, what needs to happen, what needs to be prioritized at the individual facility level. And that is it. That's the presentation that I wanted to share with you all. We are thrilled to be here and chatting with you all, and we're really excited to be presenting this and to be working with you to both pilot this, to get this live, and for you all to use it in the real world. So I put both mine and Steve's contact information here. If you have any interest in piloting this with us, Steve and I would be the facilitators. We would help you guys push through this, have that conversation, maybe come up with an after action report for you. But we just really want to make sure that the scenario flow is there. We're not missing any questions that should be asked, and maybe pick up on some of the things that just organically happen as we work through this scenario at the individual facility level. So if you have any interest in doing that with us, please let me know. I'll put my contact information in the chat, and we'll go from there. But that's all I have for you this afternoon, and really appreciate your time.
Thanks so much. And it looks like we're going to end early unless anyone has any questions. I'm trying to think if there's other questions we've received recently. I feel like there was something. Oh, flu vaccine. There was somebody who asked about how long you need to offer the flu vaccine. So I did look in the code for like nursing homes and influenza and healthcare workers, and I believe it says that you need to offer it at least once up until it's either March 1st or March 31st. So we are technically outside of that window, but again, we still are seeing some flu activity. And I think that is it. I'll leave the chat open for a minute in case anyone has any other questions. Otherwise, thanks again for everyone who's helping with focus group recruitment. I will, if we do hit the 60 people, which I'm hoping we will, we'll send an email to everyone who we dropped the flyers off with or emailed, and let you know that you can take them down. But I'm really excited. I hope we get some really good feedback from the CNAs, and we can share that then with you so that you can implement some of those strategies. Yes, Barb, what's up?
Is that 60 people total or 60 people per group?
I think it's 60 total. So